I'm Ben Ryman, and this is Behavior Speak.
If we are able to prevent that sedation, the restraints, why wouldn't we? Nobody wants to be in that position where there are six adults just pinning you down so that you can get a blood draw. Whether or not if culturally or within a particular society, whether certain sexual behaviors may be acceptable, may not be acceptable in certain contexts, but whether that is very much within that individual's repertoire to engage in that particular action or activity within that context is something that we were looking at through the assessment as well. So
we're back with episode 2 in our special series of the Constructional Approach. I encourage you to check out our first episode in the series where Awab Abdel-Jalil gives a lovely overview of the basics of the Constructional Approach. In this conversation, Dr. Madhura Deshpande discusses various aspects of behavior analysis, focusing on the transition of clients to adult settings, the effectiveness of constructional approaches in medical procedures, and the importance of active participation in achieving rapid results. She emphasizes the need for proper staff training, ethical collaboration in behavioral pharmacology, and the significance of recognizing and building on existing repertoires to improve client outcomes. The discussion also touches on the development of an app to track medication effects and the challenges faced in staff turnover within the field. Dr. Madhura Deshpande, welcome to Behavior Speak.
Thank you. Thank you. Good to be here.
Yeah, excited to have you. Before we get started, I want to acknowledge I'm producing this podcast in the territories of the Klam and Kleus, Homoko, Comox, and Sechelt First Nations. As always, I'm grateful to be here. Let's start by getting to know you a little bit. Why don't you introduce yourself and describe your work to folks who are listening?
Sure. I am Madhura. I am a BCBA. I've just recently completed my PhD in IBAO via Endicott College, very, very recently, I have to say. I work in Sydney, in Australia. I predominantly work in in-home, on-site settings, whether it's a day program or a still house, group home type of settings, with young adults and adolescents with intellectual disability and autism, and other disabilities as well. My work title in Sydney is of a behavior support practitioner, but I see myself as a behavior analyst before that specific title. So yeah, that's me.
And how do you describe your work to people outside of behavior analysis?
I look at what is within that particular setting. If there is a behavior that is not quite contextually suited, I come in and I look at figuring out what we can actually do to figure that out. I think that's how I generally phrase it.
Right on. And how'd you get into this in the first place? How'd you find behavior analysis? Do you have a certification with the International Behavior Analysis Organization, the Qualified Applied Behavior Analysis Credentialing Board, the Behavior Analyst Certification Board, or are certified through your region's Behavior Analyst Credentialing Board? You can earn continuing education units for this episode by going to www.behaviorspeak.com and clicking on CEUs. The first secret word is compassion.
So in undergrad, during my bachelor's, it was within... It was a fairly new field in Australia back then. This is 2007 when I got into behavior analysis. And there was just one center in Sydney that provided in-home early intervention ABA-based services. So I happened to be in a classroom with another behavior technician and who was working with a family who wanted more behavior technicians. So I got involved. And once in, I never really looked back. It was something that made most sense as far as interventions go. We collect data on every little aspect of the intervention. So it was quite easy to see what was effective and ineffective. So got myself into it, never got out.
Amazing, amazing. And your approach is kind of grounded in this constructional way of thinking. What drew you personally and professionally to the constructional approach?
I didn't know about it till joining the PhD program at Endicott.
Mm,
And um, during my first year, I was in Dr. T.V. Lang's class,
hmm
Technology of Teaching, and that was really my first introduction to the constructional approach. And
mm,
um, quite a lot of it, what really drew me to it was that it's not. We talk about participant assent when it comes to when it comes to learning new skills and procedures, etc. But I feel
mm,
that how the constructional approach really explains that is perfect. You should have that ability to withdraw from a procedure whenever you have to.
mm,
Your skills are constructed really on the repertoires that are fairly relevant to that context. There is access to those critical consequences regardless of whether or not you are participating in that very specific target behavior that
mm,
you are trying to learn. So all of that really that fits really well with with the context that I work in, where we don't have a very structured behavior analytical center-based approach.
mm,
We work in settings where there are multiple variables within the environment, and any one of these can act as that critical consequence. So to really identify that, that's what really it fitted the context here. It fitted the practice context really well here. So that's what really drew me to it.
mm, mm. And you've been doing behavior analysis for quite a while before you started Endicott. How did the constructional orientation change the way you did your work, and did it change the questions you asked when you started a new case?
Definitely. One of the questions on the constructional interview is when is this behavior no longer a behavior of concern? When is this behavior most adaptive? And those are questions that I wasn't asking before. There was that,
Mm,
even as a behavior support practitioner or a behavior analyst, one of the first things that you get called in for services
mm,
is the problem behavior,
right.
and to look at eliminating that problem behavior. But those problem behaviors are fairly um, suited for certain contexts. They work
Mm,
really, really well for the individual. And that really helped shift my plan and approach, really. And there are definitely contexts where those problem behaviors do not occur. So what
mm,
are those maintaining variables there in that environment that make those environments more successful? I think that definitely sort of helped shift my practice there as well.
mm, hmm Yeah, sort of the idea that there really isn't such a thing as a maladaptive behavior, that all these behaviors are adaptive and effective
Yes,
for the individual.
that's it. Yeah,
And
yeah.
and and what gets lost sort of when practice is primarily about eliminating problem behavior?
I think it really becomes almost like a Band-Aid effect
Mm,
with, say, a more traditional approaches of, say, differentially reinforcing another alternative behavior within that particular context. Um,
mm-hmm,
the alternate reinforcement for that behavior it may not have that level of potency
mm,
that the maladaptive behavior, so to speak, or the problem behavior might have. You're not going to get that uh, similar action, reaction, similar consequence.
mm,
So a lot of those interventions are fairly effective when you start off, but they might not sustain effectiveness long term because we haven't identified other contextually relevant variables that would act as effective reinforcement to um, maintain behaviors that may be more suited. Yeah.
Yeah, no, that makes sense. So, want to kind of get into the reason I found you in the first place, and it was related to this presentation you had done on EEGs, and your EEG work is a kind of a powerful example of constructional thinking applied to a medical context. Uh, what made you see EEG access as not just a medical issue, but a kind of a behavior environment mismatch?
A lot of my clients find it very difficult to access medical systems, medical settings, hospital settings, etc. And that is
Right.
predominantly due to the behaviors that they may exhibit within those settings. The healthcare system here is a public healthcare system, so the time frames and time limits that a patient may have when going from the reception to the actual treatment rooms, receiving medical interventions, and then stepping out. It all happens in a within a very tight time frame and
Yes.
quite fast. There's not much time to just wait around. And in that time, if a person is unable to accept that medical treatment, unfortunately, the most common thing to happen then is physical restraints and sedation so that they are able to access that medical treatment and get out of that setting as after receiving that medical treatment with least amount of, disruption to the rest of the system. And that was happening for a lot of my clients. And it is something that is quite scary for them to access. It's quite upsetting for parents and caregivers to see their loved one being physically restrained. And this also then resulted in a lot of parents avoiding these assessments. And
Right.
and they are quite crucial. So the participants of my study also had a history of seizures and epilepsy, and they had
Of
not
course.
contacted an EEG for quite a long time, and it was medically necessary for them to get an assessment, get the assessment done. So that's what really drew me to sort of specifically look at that medical procedure. It is a very intrusive medical procedure, and it is something that it's not unlike a blood test that you go in. It's done in about 2 to 3 minutes. The main, I guess, the painful component of it, and then you're out of there. Here, you've got to actually the procedure starts once the apparatus is on you, and then you have to wait for a very long time. So it's different in that sense as well. So that's what really drew me to it as well, that this is something that we really need to tackle.
Yeah, and there really isn't another way to do it because you can't really put them under sedation or anything because it sort of ruins the results, right?
That's correct, yes. You may get some readings of seizure activity under sedation, but it's not the most accurate representation of it.
And so how did having this constructional lens shape the way you frame the problem from the outset?
So the biggest thing was the apparatus itself. It's again, it's on your head. You can't really see it, so you can't. You can feel it, and you're supposed to sit still while it's on your body. So there were many prerequisite repertoires that were necessary to make the procedure successful. And that was one thing that really needed to be put in place before even getting into the CET component of it, the exposure treatment component of it. So there were many little steps that we could actually look at really constructing before even getting into the exposure treatment. So that's what it was quite, if I were to say, quite good fun to actually go, okay, this is another component that we are able to now tackle. Sitting in a chair for up to 40 minutes, that's a requirement for the procedure. You could lay down, but you have to lay down still for 40 minutes without getting up, without falling asleep, and all the rest of it. So there were all those repertoires to be built up.
Right. So that sounds like a key part of this constructional approach is breaking down all of these prerequisite pieces. Can you tell me a little bit about, just for folks that I haven't had an EEG for 20 years. What does an EEG entail today?
So today, actually, the clients that I worked with, what they had to, when they were undergoing the procedure, what they had to do is sit. There is a huge computer that does the readings for you. There are electrodes that go directly on your scalp, and they're attached using a gel that sticks it to the scalp, and there's a paper tape that goes on it. So there are up to 20 little electrodes that go on your head. They're attached to a wire that is attached to the computer. So if the individual moves, of course, the electrodes may come off their scalp. It would be painful as well, where if it does come off, if you're pulling it off, and the reading then becomes it's not useful anymore. You've got to start again. In order to put those electrodes on the scalp, there is a debriding procedure that takes place so that the scalp is nice and smooth for the gel to go on, and then for the electrode to go on top of it. So the clients have to tolerate the debriding procedure, the gel on their scalp, and the electrode then being attached to the scalp. So yeah, that's those are the.
So essentially, so that procedure are they shaving the head? Is that what that is, or
no,
what do you
it's
mean?
not. You can be you don't have to shave the head at all. They find a patch of scalp, and they have what can be, I guess, described best as a scrub. They scrub the place down so that there is no loose skin or any flakes that might sort of affect the way the gel then attaches itself to the surface of the scalp. Yeah.
Wow. So they have to tolerate, these invasive things. So it hasn't changed at all since I got an EEG. So
there you go.
They have to tolerate, a lot of touching and contact and pushing and scraping on the head. They have to attach multiple things being stuck to their head. They have to the cold gel feeling on their head.
Yes.
This giant computer in front of them doing things that they don't understand, flashing light at their face, and sort of so much. Not to mention sitting in a chair and getting into the room and all those pieces. And then how long is the actual scan take?
So I was working quite closely with one of the local hospitals here at the start of the procedure. So they said that at the minimum 25 minutes to get some reading. 20 minutes. So 25 minutes ended up becoming the minimum aim for the study that was done. And up to 40 minutes gives you a decent reading. So we ideally... a 40-minute reading would be what we would aim for.
So we know that's wild, and I imagine there's a lot of people listening that have had clients, probably a lot of them with adult clients as well, that are needing this kind of work. And probably not being successful, and therefore not getting what I guess that's next question is sort of what are the potential consequences for an individual if they can't have this EEG?
Medication adjustment can be something that could be quite challenging to see
Yeah.
the degree of the seizures, and then to be able to have appropriate seizure medications might be
Mm,
something that is challenging. One of
yeah.
the participants, they get quite infrequent seizures, but the seizure activity is still occurring. To even have a look at if that does cause any damage on a long-term basis. Do they get seizures in their sleep? If that's something that cannot be identified, appropriate treatment would be quite
Mm,
difficult
mm.
to access as well.
And so the EEG is able to give the doctors all of that kind of information,
Yes, that's correct. Yes.
even if the individual's not sort of having a seizure in the moment.
I think so. I think so.
Yeah,
Definitely, they might
I
not have a say.
often wondered about that.
Yeah, yeah. I don't think. Yeah,
Mm,
I don't think
yeah,
it induces a seizure. Yeah,
right,
in
right,
that
right.
moment.
Yeah.
Yeah.
So clear, definitely medically necessary, and could be a huge impact on quality of life if they don't have it. I think about a lot of the adults I've supported with seizure disorders. None of them would ever tolerate an EEG, and so they often are on really heavy, high
Yeah.
doses of medication, and that never get changed and never get altered
Yeah.
because they don't know if they're able
Um,
to do so. And the side effects of some of these things are horrendous,
yeah.
especially some of these older medications, which
Yeah.
you know about. We're going to probably get into that a little bit later with some of your pharmacology work. So, yeah, this must be huge. Have prior to sort of to learning about the constructional approach, we're going to get into sort of the CET procedure and what that involves. Was restraint sort of the only tool out there, or were folks using conventional exposure therapy? What were sort of the methods of getting folks used to EEGs or to take them?
The participants of the study had not accessed an EEG for quite a long time. So
Mm,
there is the conventional desensitization procedure that may assist, but that had not been tried, at least with the participants that I worked with. Um, Quite a few years ago. I was working with another adult client who we had initially started with some of the EEG desensitization for him, but it was very much prior to knowing much about constructional exposure therapy, it was very much stay here till the procedure is done to then access whatever your preferred reinforcer was. And it was
mm,
not the most effective, and it was taking quite
mm-hmm.
a long time to make that successful as well.
Yeah.
Um,
Yeah, it
yeah.
must be next to impossible to find a reinforcer so powerful that it competes with the aversiveness of such of any of these kinds of medical
Yeah.
sort of interventions that cause pain and discomfort.
Absolutely. And I think if we get it when we get into the CET components of it, that's what it's all about. When you want to opt out, you can, and that's when
Mm,
the procedure stops. So there is definitely a larger reinforcer available for enduring the procedure, but if there is signs of discomfort, we don't
mm-hmm,
push it.
mm-hmm,
Yeah.
mm-hmm. Well, let's get into that. So CET, constructional exposure therapy, how would you explain it in simple practical terms? And then second to that, what makes it different from the traditional approach to exposure therapy?
In the more practical, sort of everyday term, I would sort of look at it as when you want to distance yourself from the thing that is aversive, you're still able to. So when we first started doing conducting the CT procedures with EEG with the participants here with the study, the first step was the debreathing, tolerating the debreathing. If they moved, if the participant moved their head away, or if they didn't want to continue on with it, that's fine. We waited and till they were ready again, and for the procedure to take place again. At every step, the readiness of the participant to willingly participate and their assent to being touched, to being for the procedure to take place was always the first step to start the procedure. So if they did not want to at that point in time, we did not push it. So the behaviors to escape such an aversive procedure was not, the engagement was reinforced as opposed to toleration of the procedure. And I think that definitely makes it fairly different from the traditional types of exposure therapy, where in this case, each time the participant, we presented the materials, like, okay, this is what is going to happen. Are you ready? Yes, I am ready. Fine, let's get into it. This time the timer is going to be set from 5 minutes to 10 minutes or 5 minutes to 7 minutes, whatever it was. Are you ready? We're going to challenge our personal best here. Let's do this. And once they were able to identify the changes and the differences and they were okay with it, we then proceeded with the next step of the procedure. And that's, I think, fairly different as well, where there is that active participation of the individual undergoing CET too. It's not just a procedure or a script that requires following. It's almost that cross of, I'm going to do this, this is going to be the response is going to result in this, and that's the next step. So it's almost a staggered procedure that gets active involvement occurring as well.
Now, listeners that aren't familiar with exposure therapy might think that's ridiculous, that's crazy, that it wouldn't all be like that. So what happened? What would happen in traditional exposure therapy with say that first step, or with an EEG? How would they approach it? What would be the difference?
The difference there would be it would be me setting the timer for 10 minutes for the participant to tolerate the apparatus on them. If they have to tolerate that apparatus for 10 minutes in order to get access to the reinforcer. If they don't, then I reset the timer and say, no, we need to do this again till you get access, so that you can access X, Y, and Z. So there is a component of, to say it quite loosely, escape extinction also involved, where you have to stay here and tolerate this till I'm done with you tolerating it.
Okay. Yeah. So real compliance focused in that regard.
Yes.
Which, for someone who hasn't been involved with a lot of exposure therapy cases, it's much clearer to me why a lot of families and caregivers are adverse to trying it, because it sounds like it'd be a negative experience, not just for the child, but for the parents and everyone else involved as well.
Definitely. Yeah.
Okay, so let's kind of break down what you did, what it looked like. Tell me how the study went and the outcomes.
Sure. So there were 3 participants. They were all teenagers, 13, 14, and a 16-year-old. All had history of seizures in their past, or active seizure activity occurring at the time of the study. and all three of them had quite a bit of difficulty with accessing EEG. They're teenagers, their bodies are growing, so it was quite pertinent for regular checks to actually occur, and they were not able to access that. So step by step, we started off with the debriding and gel application for the attachment of the electrodes first. So again, getting them used to a lot of touching, a lot of manual handling of their head, faces, etc., and for them to be quite okay with it. We also I also trained the parents and with two of the participants to conduct some of the procedures on a regular basis as well, so that they do get in that hospital setting, if they have difficulty with a new person engaging in any of those procedures, the parent may be able to step in to just assist a little bit if they are more familiar with what they need to do. The second step from there was to actually tolerate the EEG sensors. So we used actual sensors, medical sensors within the study, and they were attached using a tape or a clip. At this point, we had the whole procedure up to attaching the EEG sensor was conducted each time. So the debriding, the application of the gel, and then the clipping of the EEG sensor itself was done each time. And then we looked at increasing duration, increasing the number of electrodes, and then increasing the duration with the target number of electrodes being on the head. And yeah, a lot of each child or teenager required at least three exposures or 3 sessions per day, so that they were fairly familiar, fairly used to it. And we looked at gradually increasing the duration. Once they were able to tolerate all the electrodes on their head, we were looking at quick but gradual increase in duration from there.
And so how quick was that? How long did it take to go from having someone moving your hair around to accepting 20 electrodes on your head?
3 weeks.
3 weeks, wow.
Yeah.
And that's over, you said 3 exposures a day, or did the 3 go up, or was that just 3 a day of increasing amounts of the procedure?
3 a day. It kept to 3 a day, only because by the end of the study, the participants had to tolerate that for about 20 to 25 minutes. That was required for the minimum reading. So if we were to increase that during the day, kids were at school as well during that time. So it was going to be quite time-wise, quite challenging for this to occur for more than 3 times a day. So that ended up becoming a bit of a routine for all the participants as well. So yeah.
So the eventual goal then was to get 3 25-minute sessions in a day, sort of by the end of that 3 weeks?
Yes.
And so for that first couple days, those exposure sessions might have been quite short, or like what did that look like? How sort of quickly was the increase in steps and increase in acceptance of all of this stuff?
I think the initial steps actually were quite quick to acquire for all the 3 participants, where although they started at 0 baseline for accepting any of the procedures, with the increasing the touching and the debriding, increasing the areas of the scalp where that happened, that happened very much within the first few days, and we started increasing the placing of single electrodes first, increasing the duration there, and then multiple electrodes and increasing the duration there. So the first few steps of the debriding steps did not take more than 3 or 4 days. I'm just looking at the graphs on the side here as well. It did not take more than 3 or 4 days across the 3 participants. As I said, the longest bit was the increasing of duration of all the electrodes on the head and increasing it to the 25-minute mark. So that took about 10 days, yeah.
So were they refusing to participate a lot in the beginning and that sort of declined as you went on? And so did you get to a point where maybe they had 18 electrodes on their head and then they didn't want to do it and so you took them all off? Is that what it would look like, or?
So it would sort of build on from where we sort of left off previously. So if we were at, say, 5 electrodes, these electrodes were colored as well, so they could actually select which one went on when. They, with one of the participants, they liked to watch certain videos, halftime Super Bowl videos. That was their jam. So, which were long durations, and they were reserved for the procedure as well. Okay, let's watch them while this is these electrodes are on. So at any point in time, if there was refusal to engage, we would stop right there, do something else, and then come back to it. Are you ready for it now? There was a condition that if they wanted the apparatus to come off before that target duration were to be achieved, it was the person implementing the procedure, either myself or the parent. They would be the ones to take it off. That was the base condition there as well, because we don't want them to be in the medical setting and for all these electrodes to just be disconnected from the unit. So they had to wait for the other person to take it off, and they would be taken off, and then we would start at that point again the next time.
And so, did you find more that folks were okay with sort of leaving things on and just taking a break versus wanting everything off? Is that what it tended to look like, or?
Yes, it did tend to look like that. With one of the participants, he found it very difficult. The procedure is very difficult in general, just to remain seated for that long period of time and for to tolerate the touch, etc. But we never went back from tolerating the 10 electrodes to 0. It was always the duration that was quite challenging for him. So yeah. Which was, I think, the biggest component of it. There was nothing, we never had to go, and he did get to the 25 minutes as well, just it took longer for him than the other participants, but yeah.
Yeah, you talked about prerequisite skills like sitting in a chair for 40 minutes. Was there teaching on sitting in a chair for 40 minutes first, or was that just built into the whole procedure? So once they had everything on their head, now we're gonna work on shaping sitting in the chair.
There was a little bit of the training done before starting of the procedures. 40 minutes is quite a long time. So we were looking at items, leisure items more so, what would actually keep the individual engaged, and things that they can take with them to the hospital setting, whether it's a puzzle, an iPad, a coloring in book, whatever it might be, or even Zoom, talking to somebody else on Zoom while the procedure was being conducted. All of this they could have actually done within that hospital setting. So we were mainly, we built that up a little bit first. So this is something you can do while you're seated, and then introduce the procedures throughout.
Right. And what did reinforcement look like? How was that? Did the participants select reinforcers and they're provided after each step? How was that all put in place?
Some of it was very much embedded. So if there were preferred videos, etc., to that the participant liked, that was something that they could access during the procedure itself. One of the participants really wanted to get to like a personal best and get a certificate. So that
Nice.
he was. He really got the idea that what we are doing is really increasing the duration. So he wanted to challenge himself. So after the first few sets of procedures, he that ended up becoming quite almost like a fairly a motivating thing for him to sort of keep going with the procedure. The young girl, she had other. She definitely wanted to get rid of the whole procedure itself. So just wanted to sort of once in the doctor's office get the procedure done, so it doesn't have to do it for a very long time. So that ended up becoming a final, I guess, reinforcer for the whole procedure. But she loved praise and that. Oh, this is so cool! You've got all the blue ones on you. Do you want the yellow ones on you? And the social engagement that sort of comes with it was very much a part of it. Yeah.
The second secret word is endicott. So it ended up that everybody was successful getting an EEG, and then was there any sort of follow-up in terms of were they able to get another one later, or?
They're all currently my clients, all the three. So one of them, the oldest one of them, who did find it quite challenging, he is going to be an adult soon. So he is changing the medical systems for him. The healthcare systems are changing from pediatrics to adults. So he's has recently undergone an EEG. When he just recently entered the adult hospital setting. So it's going fairly well for all three of them.
And did they require, like, it's quite a bit of a time difference from one EEG to the next. I don't know if they're annual things. I guess it depends on sort of the work they're doing. Did it require some booster sessions and that sort of thing?
Yes. Yeah, they did. One of them, definitely, the one who was transitioning to the adult setting, he did. So we have a set of all the equipment in his home, and we sort of prep for that as his appointment did come up. So yeah,
that's amazing. Have you had experience or seen this procedure applied with folks who maybe are minimal speakers or non-speakers, or maybe have higher support needs, and seen it successful as well?
Yes. So the adult client, or rather now an adult client, he is a minimal speaker.
Okay.
Yeah. And he has required quite a lot of supports across many domains: communication, self-care skills, etc. He's living at his parents now, but he will also be moving out to a group home setting next year. So it was fairly successful with him. There are different procedures, I guess, different CET procedures that have been conducted, not an EEG one, that have been also successful with other minimally speaking, high support need clients. So, yeah.
And can you talk a little bit about what some of the assent procedures looked like with that fella compared to the folks that were speaking, where you just had to sort of explain, we're going to go this and this and this?
It was initially with the debriding, even approaching the head with either with your hands or with the Q-tip that would then apply the debriding gel, ready, and just showing them the equipment. This is what is going to happen. and for them to be okay with it. If they moved their head even a little bit, I would withdraw myself in that moment. If they tolerated it, excellent. They got other additional reinforcers for that. Yeah.
Well, that's amazing. Have you seen this? I've heard of this being used with a variety of medical procedures. Have you seen this this work with sort of other procedures with some of your clients at all?
So I'm currently running a procedure for blood draws.
Wow.
And we are at a point of just tolerating a tourniquet around the arm. And this is, again, a 35-year-old individual with quite profound disabilities. And we're looking at going very step by step as far as the procedure goes. In the past, it's not a medical procedure, but I've used a similar procedure for vehicle desensitization, where one of the participants wouldn't step into a vehicle at all. So she was missing out on a lot of community-based access, whether to the shops or even to school. She was unable to go to school. So that was fairly successful.
Tell me a little bit about that one. I know I have a lot of listeners that work sort of in adult context, often in group home context. The van ride is either the biggest reinforcer or the biggest punisher. I'd love to hear a bit about how that went.
So that went eventually, it was very, very successful to procedure for this young lady. She was in a group home context. She was the only resident there, and she had, about 6 months before I started working with her, was in a vehicle accident with her grandmother.
Wow.
So it was a fairly scary thing for her to return to go into a vehicle. Within the group home context as well, the vehicles that were used by this company varied too. They didn't have a standard vehicle that they would use, so that also caused a little bit of hesitancy in getting into a vehicle at all. So she had not when I'd started working with her, the accident was about 6 months prior. She had then moved into the group home. So she had not been to school for over 6 months in that time. She had not contacted any medical settings in that time. She had not gotten a haircut, etc. So there were a lot of those everyday things that were being quite severely impacted.
Wow.
So we literally started off with being in the garage with the vehicle present, touching the door of the vehicle. And if you don't want to, that's fine. I'm going to just touch the vehicle and come back. You want to do it as well? Let's go. And then sitting in the vehicle while watching something cool or listening to your favorite music. And slowly building up from there, just reversing the vehicle out of the driveway, going up and down the street, etc. Yeah.
Well, that's amazing. Really cool. I'd like to get into a little bit around sort of some of the how the constructional lens feeds into sort of the ethics of all this. How does constructional thinking challenge some of the default practices of sedation and restraint?
I think it does provide that alternative we do require that time to prepare, but as far as CET goes, it takes the amount of time required is much shorter. So which is very cool. I think the biggest thing about CET procedures is how quickly some of the results are achieved and acquired. One of my fellow PhD students, colleagues, Danielle Cohen. I don't know if you've met her, talked to her.
Yep, she's coming on in a couple months. Yeah.
Oh, perfect. Yes.
Yeah.
She conducted CET with a young individual with nail clippers.
Yes.
And achieved such fantastic results within an hour, which I
Yes.
find so fascinating and so amazing. There's Katie Gibson as well, who is doing amazing
Also coming
stuff
on. Yes.
fantastic. um, um, and that is very much life-saving, what she has done. And all of those results were achieved in such a short amount of time. So with enough preparation, I think if we are able to prevent that sedation, the restraints, why wouldn't we? Nobody wants to be in that position where there are 6 adults just pinning you down so that you can get a blood draw. It's going to be aversive for anybody involved.
And why do you think that is? Can you sort of speculate? Because I think that's one thing about the constructional approach that has really blown my mind. I've kind of gone to the last 2 free Endicott conferences, and some of the case studies have just been mind-blowing. And then saw Danielle's and saw Katie's presentations, and the nail clipping one is just,
I know.
I think the session was an hour, but the actual trials were like 11 minutes. So it was 50 minutes of breaks. And had this kid who hadn't clipped his nails in 10 years. His mom was clipping his nails while he was sleeping, clipping his own nails in a couple hours, and getting praise from his dad. It was just mind blowing. What do you think that sort of tells us about some of these contingencies in place, some of these really difficult routines that we struggle to get our folks to participate in, that just by including some of these assent procedures, we're getting these dramatically quick results. The animal results are equally amazing.
Absolutely.
Getting a bear to lick your hand after 10 minutes, and this was one study, and dogs that are never getting adopted being leaving the kennel at the end of the day. Like these are stories that I remember. I was telling some of my colleagues when I went to the first conference. I think it was Dr. Adronis was talking about getting a guy who was deathly afraid of vacuums to start vacuuming in half an hour, and some of my colleagues were like, Ben, you shouldn't be telling these stories. You're making stuff up. This can't be happening. What do you think is kind of happening that, and there's sort of this, we often hear this concept, well, there's a long learning history, so it's going to take you a long time to kind of get through these things. Why is this change happening so quickly for these individuals? What do you think is going on?
I think it is that active participation, and we are building on their already present repertoires, as opposed to attempting to avoid their reaction to these aversive stimuli. We are looking at, distancing is okay. You can, and we saw that example in the nail clipping videos Danielle had presented as well, where when the child said no, Danielle also stopped. So the practice of saying no is reinforced, as opposed to the more challenging, bigger reactions to aversive stimuli. You don't have to put that much energy to distance yourself. And those, I guess, smaller degrees and smaller magnitudes of behaviors are just as powerful. And once I think whether that's a child, an animal, once that is established, that there is a bigger reinforcer available for engagement, but you can withdraw and you are able to access those reinforcers other ways. I think that's a very critical thing to look into. That boy is going to be praised for other things that he does. Praise is never going to be withheld. Praise specifically for the nail clipping was provided. So there are other ways to access those reinforcers as well. It's not just tolerate this desensitization procedure and get through it. It's you engage in it, and you get access to these really cool things as well. So
you also kind of work in areas where culture, religion, and values strongly shape what care looks like. How does a constructional approach help clinicians navigate areas like, well, certainly autism and sex education, things like that?
I think so. One of the other projects that I recently worked on was an assessment tool for individuals with profound disabilities and sex education. So looking and what that really looked at was the repertoires that were present as reported either by the individuals themselves or by their caregivers. So it looked at very much what skills are currently within the individual's repertoire. What do we actually need for safe safe sexual relationships and safe sexual interactions with other individuals. Something that constructional approach or approach does is it really very much objectively looks at repertoires. At the end of the day, whether or not if culturally or within a particular society, whether certain sexual behaviors may be acceptable, may not be acceptable in certain contexts, but whether that is very much within that individual's repertoire to engage within to engage in that particular action or activity within that context is something that we were looking at through the assessment as well. So.
And what are some of the common mistakes when practitioners don't slow down to understand family and cultural context?
It is. I think what we sort of sometimes rush into, I guess, is not identifying reinforcement contingencies and punishment contingencies within that particular setting. So I think when we rush into that, I think that's where we might get a little bit more of a pushback from schools are a good example. There is definitely, there are very rigid rule sets there. And that might subtly change from school to school. And if we were to push on that without actually understanding what contingencies are available for that for the personnel there, we are going to get a little bit more of a pushback, and it's just means delay in the kind of assistance that our clients need within that particular setting.
You just finished your PhD. Congratulations again.
Thank you.
It focuses on adult services, staff training, systems, which is a huge piece. How does constructional thinking show up at a systems or workforce level?
So a part of the study that was done for staff training, for the staff training component, was we looked at the constructional interview to get staff input on what is required within that setting when. With the participants that they work with, what are the repertoires that the participants themselves have? What are they successful with? What are they finding challenging? What finally is the terminal outcome? Why are you teaching what you're teaching to this individual? What would you like to get out of it? And if you were to say this was a perfect day for you with this particular participant, what does that look like then? What is this person doing on that perfect day? They're engaging in their work tasks and activities. They are transitioning from one setting to the other without being distressed. I'm able to assist them with the things that they're after. They're able to communicate what they want and don't want. They're able to follow a routine of this particular setting without too much of a hiccup. And staff were not necessarily asked that. They were given a script to follow for the day, and they had to pretty much tick boxes. So that was a fairly important component within that systems level staff training, where they were able to identify and that actually, from the constructural interview, we did end up going into a full functional behavior assessment for those specific participants as well, where we then looked at functions. If there were potential problem behaviors that were occurring, what is really reinforcing that, what is maintaining that at the end of the day, and looking at making changes, like teaching specific skills that suited the day program environment, that also built on accessing the relevant reinforcer for them. If it was an escape maintained behavior, for example, getting through a certain a task and activity gave them a large break fairly naturally, as opposed to having to engage in problem behaviors.
Hmm. Hmm. And tell me a little bit more about the kind of big picture, what your dissertation questions were, and some of the outcomes of your study.
The thing that I looked at was care and counterfeit care. So care within because it's such a I guess a ubiquitous word that gets thrown around within the industry, and what that actually means. So we looked at critical features of care, variable features of care, and what counterfeit care actually is. So it really it looks at it's an imitation of or attempts to appear as care, but it is definitely missing some of the critical features, which can include keeping the person's rights with as the center point, ensuring that there is that active skill building that is occurring within these settings, not just running things for the procedural requirement of that particular setting, etc. So that was one of the questions that was that definitely became a bit of a I guess it sort of set the theme for the study.
It would,
and following that was what is going to help in sustaining maintenance and generalization of staff training once a staff member is sort of provided instructions in terms of what is going to make this particular individual really successful within this particular context, what is going to actually sustain it long term. So that led to the more pyramidal, systematic staff training questions from them.
Yeah. One of the things that kind of stood out for me was we were talking about kind of multi-tiered staff training. High staff turnover is seems to be the one of the biggest problems in sort of adult services. I was supervising a consultant working towards getting her BCBA, and she does a lovely job. She's a great trainer. She builds great rapports with teams and builds really lovely interventions. And she was, so happy with the work she had done. And then suddenly the individual got a new manager. Suddenly all the staff changed and she was back to square one. The individual's back to all the problems again. And she kind of, ran out of service hours because she had limited service hours to coming in, and now she's got an individual who's back to having horrible quality of life. I imagine this is something that you run into and everyone
Yeah.
runs into. Were you certainly you can't solve all the world's problems in one study, but were you able to come up with some ideas on sort of to give us a little hope that maybe it doesn't have to be this way?
I hope so. I hope I can give some hope. But what was really cool, there were many really positive side effects, so to speak, when the study was occurring. So the way it was set out was, yes, the staff turnover definitely is a major issue in a lot of adult care settings. So the way the study was also sort of set out was it was within a day program setting, and there were coordinators of some of the programs that the day program provided. They were the main participants of the study, and they identified staff members that they wanted to train. So it was almost, I guess, a train the trainer type of model using BST, where the coordinators trained the ground staff members using BST. They taught them how to write up task analyses. And what that ended up doing was it did spread across the ground staff level staff members. So it did sort of trickle across not just the staff members that the coordinators selected, but even across the other staff members who were also working with the participants of the day program alongside the target staff members, so to speak. So the trickle effect was definitely something that was quite cool to see, I guess, that created that system-wide sort of, this is a better technique or this is a cool technique. Let's try and see if this is effective for my participant. Yeah.
Yeah, and that seems to be a key piece is the systems and training others to do the training sort of when you leave. And this might not have happened in the context of your study, but how far up the chain do you think you need to kind of go when you're doing this? Are we talking to CEOs and HR directors and just in terms, I'm thinking about it seems to be, if you look at a lot of these companies, there's a certain level where the staff stick around. and that's that pay grade where they stick around, and the lower pay grade folks tend to depart. And so you really need those upper pay grade folks to, be the keepers of knowledge, I guess, to pass on to the next set of folks. What's your experience been there?
I think yes, it's definitely the pay grade component of it, because usually the ground staff members are all casual staff members who are doing this as a college prac or something similar. So yes, the pay grade component of it is definitely a factor, but I also feel the ones that design say the programs for some of these settings, where I feel they should be definitely involved within the direct training of staff as well. They're fantastic staff members, but they're the ones who are, I guess, mainly setting the function of the setting, and that's something I think that would be very beneficial. Even looking at the day program that I did the study at, the coordinators are fantastic. The training is still being maintained, but once they leave, it would be another, I think, another, I guess, a training that would have to sort of take place. Yeah.
Yeah, and I guess it also makes me think about, and I mean, I think it just depends so much too on funding and things like that as well. I mean, I think this is the place where the system I work in. I'm in Western Canada, and we at this point we can't keep providing, a booster session every 6 months or every year, even though it would only take, maybe a couple hours here and there. We have to move on to the next case and to the next case and the next case. And I think that's where it becomes frustrating for folks is there's no way to sort of keep a pulse on things.
That's very similar to what it's like here as well. There's limited funding available for staff training. And I think the more we are able to the more we can do in those 2 hours, the better it is for the participant, and that's where generalization and maintenance of those skills is so essential. That it's not just about a single procedure within a setting and with one specific participant. It's about sort of transferring that skill to a different participant with a different skill. What would that actually look like?
Yes. I want to talk a little bit about a little shift towards your behavioral pharmacology work. When we last chatted, you were working on an app.
Yes.
I wonder if you could tell me a little bit more about that and what the app is and who's involved and why you decided to work on this project.
So that particular project was sort of developed during a behavioral pharmacology class conducted by Dr. David Cox at Endicott. And we were me and my classmates, we were discussing how we are all in systems where we make decisions on a behavior support plan, but the participants, a lot of them that we work with, have pharmacological interventions in place, either prescribed by a psychiatrist or being put in place as a chemical restraint, and we might not have. We have to have an input on how it's being used or when to implement some of those restraints, but we don't have much of an input in terms of what effects those medication may have on either the individual or the intervention itself that is currently in place. So the app that we developed is using Google App Sheet and the paper that is currently in preprint, but what it does look into steps to, it's very much, it's quite editable, and you can sort of put in information that you want to capture. You can calibrate it to that. But what it really looked at is medication administration, what the behavior looked like, and the medication's effects, whether the behavior intervention that was prescribed to the family, whether that was used or not used, and whether that was effective or not effective, when the medication was administered, whether that medication then helped reducing or increasing the behavior, etc. But the data that was procured for this particular study is neutral. We are just collecting observation data that is to be collated and that can be provided to a prescribing practitioner who can then make decisions on medication, whether it's effective or not, as well. Yeah.
Really cool. And so is this something that might be available for folks to try in the future?
Yes. Yeah. It will be. Yeah. It is. We've submitted to BAP. Let's see what they think of it all. If they like it, it would be available. Yeah.
Amazing. Right on. And how does maybe a constructional lens fit in here and shape ethical collaboration around medication?
I think what is really something that we found was actually lacking was data that is collated and collected across both behavior and pharmacological effects. And I think that's what is going to prompt collaboration as well. And there is that, there's now a platform, there would be a platform where collaboration can be more readily be available as well. So I think, and which is missing ethically, like from a behavior analytical lens, data is something that we make all our decisions on. And if that data can be shared to make those decisions along with another practitioner, I think that would be fantastic. I mean, that would be like, I guess, the starting point, and then we can sort of go from there.
Yeah, really cool. One last question. If more behavior analysts truly adopted a constructional orientation, what do you think would change most in practice systems or in how our field is perceived?
I think that's a massive question. Yeah. See, I think I feel the component of recognizing relevant repertoires and building from there is very much the way to go, and that's what actually gets those rapid changes that we saw during the conference as well. And a lot of the times when challenging behaviors are viewed pathologically as something to be eliminated, I think that's where we find it, we are going to find it most challenging to enter those sort of settings, and we might get that resistance if all we are doing is trying to put a stop to those behaviors without actually recognizing why it's adaptive within that particular context. And if more behavior analysts take that constructional point of view, we are going to look at those relevant repertoires. We are going to take a look at those critical variables that allow for certain behaviors to be more adaptive than others. And we would be able to sort of take that step back and teach more meaningful skills within those settings.
Yeah. And I also wonder, this focus on already existing repertoires, I think is a real game changer in terms of maybe some of our biases in how we've perceived the competence level of the folks we serve. And I don't think we've always come into this role with a presumption that the folks we serve, especially those who are minimally speaking, have any level of competence to make change. I still have, there's a quote from a parent in a program I worked in years ago, he said to me, it was in a group home that I worked in, he said to me, I don't know why you see, I don't know why you keep trying. I have never thought my son would ever contribute in any way to this world, and never had the capacity to contribute in any way to this world. And I don't know what I was doing that was special at the time. This was 20 years ago, but he was sort of refreshed that someone thought there might be some capacity there. Does that resonate for you, that the constructional approach can really change the way we look at the folks we serve?
Absolutely. I think, say, a lot of the assessments and tests that are conducted, they look at what's not there rather than what's there. Why this person is not meeting, I guess, the expectancies or the criterion that is required for a certain setting, not necessarily at what they can actually already do fairly efficiently, that can then build up to a more successful participation within that setting, whatever it might be. And I think that shift is definitely required for us to see what else is sort of available to our individuals that we serve that they are going to be fairly successful at. If I can just sort of digress a little bit, one of the participant that we talked about during the EEG study, the one who does not, who requires quite a bit of supports and he is non-speaking. He also had a fairly what the parents and the family found it fairly challenging during family gatherings. So he comes from a very large multicultural family who get together every Sunday for huge lunches. What he would do is pick up plates and empty them off into the bin, or take water or drinks that were on the table, tip them out, etc. And he loved the texture, I guess, the wet texture of food, and but he also loved water. So what we ended up doing for him is teach him how to do the dishes. As a side effect, a kind of positive, I guess, side effect of the whole EEG study was waiting. Waiting was achieved really well. So we waited till everybody was done eating.
Interesting.
He could then collect the plates, take them to the kitchen. He also engaged in these behaviors because then he was asked to, "Oh, you're getting too worked up. Why don't you go into this other room, play on your iPad instead? I know we are getting a bit noisy for you." But doing the dishes in a busy family party, I guess, a family gathering, means that the kitchen is not that populated. It might have an aunt, or it might have a grandparent helping you out, but the rest of the family is in the backyard. So it provided him with a quieter space. He could do the dishes. He could take as much time as he wanted. He was playing with water and the soap and the stuff that he liked. So we could really build on this an alternate skill that had really nothing directly to do with him emptying plates and emptying glasses. But it did sort of help not just build a completely different repertoire, but also based on his already present repertoires, but also provided him with the critical reinforcers that he was after. Getting out of that busy setting, playing with water, and all the rest of it.
I mean, that's the reason we all escape to the kitchen to do dishes during a big party, right?
Right. Absolutely.
An absolutely awesome repertoire to have. Really cool. Madhura, thank you for modeling what constructional, ethical, and culturally responsive behavior analysis can look like in real life. Not just in theory. Really appreciate you coming on Behavior Speak.
Thank you. Pleasure to be here.
Awesome. The third secret word is interview. You can find us on Instagram and TikTok, and subscribe to our YouTube page at Behavior Speak. And if you enjoyed this episode, please leave us a review on Apple Podcasts or Spotify.